to speak today on this topic. I think it's important to understand that all of us, in whatever aspect of reproductive medicine that we deal in, deal with the concept of not just embryonic development, but maintenance of that early embryo and that early fetus. When we talk about the development of the embryo post-conception, there's clearly the embryo immediately after conception, but pre-implantation. What is critical, though, for a continuing pregnancy is implantation and the development of placentation, that early differentiation of cells that leads to the placenta and the fetus. And then finally, organogenesis, which takes that embryo from the embryonic stage into the fetal stage. Our work with couples and women with regard to successful pregnancies obviously involves the common occurrence of spontaneous loss. And while all of you in this audience are very familiar with the issues of the definitions of that, let me just go through them quickly. Spontaneous abortion or miscarriage is defined, as you see here, as the involuntary termination of pregnancy before 20 weeks gestation. After 20 weeks gestation, it's considered to be a stillbirth or a premature birth. And when we take a look at the etiology of loss in a very broad stroke, losses that occur after 20 weeks tend to have a different etiology, not always, but tend to have a different etiology than those losses that occur before 20 weeks. And again, a single loss is tragic. In a sense, we are called upon to evaluate that woman and support that woman at that time of loss. We then, however, need to consider recurrent pregnancy loss. And while we all understand that the risk of miscarriage or the risk of loss is actually rather high, it's believed that perhaps up to 50% or even more of all pregnancies end up in miscarriage or loss. We have a group of women, a group of couples who suffer through recurrent pregnancy loss. Now, when I was a resident, and that is a long time ago, recurrent pregnancy loss was defined as 3 or more consecutive spontaneous losses or miscarriages. However, now recurrent pregnancy loss is now considered to be 2 or more spontaneous pregnancy losses, not necessarily in a consecutive fashion. And what that change in definition has allowed reproductive medicine specialists like myself and like many of you to evaluate that woman and to evaluate that couple to see whether or not they have something that is leading to these losses. So when we take a look at the etiology of loss, honestly, that is a presentation unto itself. But just in one slide's worth, early pregnancy losses, and we're talking primarily losses before 20 weeks, first and foremost, the major reason are chromosome abnormalities. Now, most of those chromosomal abnormalities, the vast majority, are random aneuploidies, an extra chromosome 16, a loss of chromosome 22, 45X. There is a much smaller group in which there is an inheritance of an unbalanced rearrangement, but that is definitely the far less common etiology for an embryonic chromosome abnormality. There can be anatomic abnormalities, both congenital or acquired. You can have immunological aberrances, for example, thrombotic complications of the antiphospholipid syndrome. Inherited thrombophilias like factor V Leiden that can lead to early problems with the placenta and thus loss. Infections still play a role, and depending on your community, and a lot of comorbidities may play a greater role. And then finally, there's endocrinopathies, and that's what we're going to focus on the rest of this presentation today, and in particular, the luteal phase deficiency. So that early embryo, as you all know, requires progesterone in addition to other factors, but we're going to hone in on progesterone because it's progesterone that at elevated levels, which occur after conception, those elevated levels maintain the corpus luteum, which in and of itself maintains the production of progesterone. And we see this in many mammalian species. Now, we have done, or there have been done some elegant studies decades ago that show that if that corpus luteum is removed before a particular gestational age, the pregnancy is almost invariably going to fail. However, after that gestational age, the corpus luteum can be removed, primarily because at that stage, which is somewhere with human gestations to be around 12 weeks, placental production of progesterone is able to take over and maintain progesterone production. So what is this magical hormone progesterone when it comes to maintenance of that early pregnancy, the embryo and the early fetus? So clearly progesterone is necessary for successful implantation and the maintenance of pregnancy. What exactly does it do to maintain that pregnancy is not specifically identified. There are a variety of mechanistic processes that it's believed that progesterone plays a critical role. One such role is potentially the immunomodulatory actions of a pregnancy protective shift from that pro-inflammatory cytokine response to a more favorable anti-inflammatory cytokine response. Again, remembering that for that woman carrying that embryo or fetus, that embryo or fetus is in fact a foreign body immunologically. And so progesterone is thought to modulate the immune response and allow the pregnancy to be maintained and to continue to develop. Now, that being said, understanding the critical role of progesterone, obviously, over the past decades, many of us have looked to progesterone or progestins, which are synthetic molecules that have progestational effects, to potentially be able to maintain pregnancies where natural progesterone is insufficient. Well, we have looked at this. We have looked at this with large trials and large meta-analyses. And just in general, I think it's been well accepted that the progesterone or a progestin does not show benefit for reducing sporadic miscarriage rates. And so while lots of women get progesterone to reduce the likelihood of miscarriage, I think it's well accepted that except in very rare cases, does not work. However, in these trials, in these large trials, there have been a subgroup of women who have recurrent miscarriage. And in fact, some studies, not all, have shown a decrease in miscarriage. Some have shown no effect. And we're going to talk a little bit more about that in a moment. So the basis for potential benefit in women who with recurrent pregnancy loss is that it is in some way treating or maintaining the luteal phase, that there is some sort of luteal phase deficiency that is not allowing for the production of adequate amounts of progesterone that lead to miscarriage. And in some way, this is something that a woman or a couple is predisposed to that leads to recurrent miscarriage. So success of early pregnancies is truly dependent on that corpus luteum producing progesterone until about 7 weeks gestation in that way. That 17-hydroxyprogesterone, which is produced by the corpus luteum, but not the trophoblast, so it's a different progesterone molecule, we're able to show that 17-hydroxyprogesterone does in fact able to maintain and indicate that a shift from that corpus luteum-based progesterone to a placental progesterone does occur gradually. It's not something that it's an on and off switch. It's not turning on a spigot here and turning off another one there. But it takes several weeks for that to happen. Again, getting to that 11 to 12 week gestational age, at which time placental progesterone takes over entirely and the corpus luteum is no longer needed. So what we have here is that progesterone concentrations in normal and abnormal early pregnancies do reflect the combined contributions of the corpus luteum and the developing trophoblast. So you can imagine that a conception with an abnormal chromosome complement is likely to have trophoblastic alterations that impact and adversely impact the production of placental progesterone, which is likely one of the main mechanisms by which abnormal conceptuses result in a considerably higher rate of spontaneous loss. So again, many of us and many of our teachers and mentors spend a lot of their careers measuring serum progesterone levels to determine the quality of luteal function. Is there a particular progesterone value that one needs to achieve in order to maintain pregnancy? And the answer to that is maybe yes, but we don't know. What do you mean we don't know? It's a wide range. There's a wide range of progesterone that's specific to a woman and to a pregnancy. And in fact, aside from evaluating and measuring very low levels of progesterone, which can reflect a defective corpus luteum, that assessment or trying to determine whether certain progesterone levels are associated with successful or unsuccessful pregnancies doesn't really work. So nonetheless, where we have potentially a luteal phase deficiency, this has led to the concept of progestational supplementation to support those early pregnancies and thus reduce spontaneous pregnancy loss. But there was a concern. And the concern is if we're maintaining the corpus luteum, remember, this is before we get to placental progestin production or progesterone production, would in fact providing progesterone to counter the luteal phase deficiency, would it support the continuation of an abnormal conceptus? And this is actually looked at, and I'm going to show you the next slide in a moment, from work done from my former mentor, Jolie Simpson, and my colleague, not my former mentor, my mentor, Jolie Simpson, and my colleague, Owen Phillips. They looked at the frequency of fetal to newborn abnormalities in women undergoing progestational therapies for recurrent pregnancy loss. The concept being is those women who got progesterone, did they have a higher likelihood of fetuses with chromosome abnormalities? And the answer to that is no. This was published in 2008. And in fact, it has been reaffirmed with other studies that progestational therapy does not increase the likelihood of a chromosomally abnormal conceptus. So since we do not have evidence of any change in the frequency of genomic or chromosomal abnormalities in pregnancies, we can in fact, in a sense, go forward and consider the use of progestational therapies in women who have recurrent pregnancy loss to potentially maintain early pregnancies that are likely to be successful and genetically, genomically, or chromosomally normal. Well, the best laid plans, as we all know, don't necessarily take hold. This is a relatively recent study, 2015, with some other studies afterwards that in fact showed that progesterone therapy, and I'm specifically saying that did not include dydrogesterone because the end of this presentation is going to talk specifically about dydrogesterone, which is again a synthetic progestin. But looking at a variety of progesterone therapies in this large prospective trial did not result in a significantly higher rate of live births. So again, as I mentioned earlier, we have evidence in the literature of benefit of an increased frequency of live births, and we have studies like this that show no such benefit. And the reality is that prospective trials like this do carry a bit more gravitas, a bit more weight, because they are not backward looking. They are not retrospective. They take into account that may not take into account certain biases. Prospective trials obviously are perhaps give us a more robust answer. So as I mentioned, that large study did not include dydrogesterone, or I believe its brand name around the world is Dufastone. Progesterone and dydrogesterone are pure progesterone receptor agonists. Dydrogesterone is a somewhat different progestin than the other progestins that have been used for contraception, menopause therapy, as well as maintenance of pregnancy. They're synthesized, they're plant-based synthesized products. Dydrogesterone is actually considered a retroprogesterone, but it has a similar effect at the progesterone receptor as endogenous or native progesterone. And it's believed that that in and of itself makes it a somewhat different synthetic molecule than some of the other synthetic progestins that have been used. So we do have actually some considerable support for dydrogesterone providing benefit in women with recurrent pregnancy losses. One of the first studies was in 2012 by Karp and colleagues that showed that while it was not a very robust blinded placebo control, lots of factors were not controlled for, but outcomes showed a significant reduction of 47% in the odds for miscarriage in those women who used dydrogesterone compared to what was known at that time standard care, which could have been other progestins or no care at all. And that in and of itself leads to some of the issues with not controlling all of those confounding or predictive factors. But at the end of the day, there was a profound reduction in risk of miscarriage for those who did use dydrogesterone. This was followed up by Kumar in 2014 that in fact showed that the use of dydrogesterone in women with recurrent abortions did in fact improve outcomes, reduced spontaneous losses, and improved the gestational age and baby weight at delivery. And then finally, Siu in 2015 showed that micronized progesterone, which is another oral progestational therapy, led to a greater increase in serum progesterone and progesterone-induced blocking factor levels, again, thought to be another mechanism for maintaining pregnancy, but had absolutely no difference when compared to women who used dydrogesterone as far as clinical outcomes. So different physiological effects, but in fact, no significant difference in their clinical efficacy to improve outcomes. So this sounds like a very good molecule drug to consider in women with recurrent pregnancy losses. And in fact, two randomized trials in 2017 and 18 showed no safety signals, no difference in the rate of congenital abnormalities in newborns that were exposed to dydrogesterone compared to those exposed to micronized progesterone. And in fact, to this day, today, there's no verified data set showing any risk for newborn abnormalities in pregnancies exposed to dydrogesterone. However, I'm going to show you in the next slide, there was a paper published that without a validated data set was published briefly and then was retracted. So there is not even a paper that has maintained publication that shows a concern about congenital abnormalities. But it is that fact that it came out, and even though it was retracted, that has led professional societies to consider safety concerns. And not that there are safety signals. They even state there are no safety signals, but the use is in question or the data are insufficient at this stage, except for the fact that the safety data that has been published on dydrogesterone is in fact comparable to the safety data that is found with other progestins. So here was the article. It was published again in 2020. There was this expression of concern, the fetal safety of dydrogesterone, not a validated data set. And then it was, as you can see, retracted. So again, there is this concern of safety based on nothing in the literature. And there is the problem. I think all of us in reproductive medicine deal with innuendo and deal with rumor. And yet we look to the literature to counter that innuendo and concern. And in this situation, to look at the literature, you'll find no safety signals when it comes to dydrogesterone in large prospective and observational trials. So how do you prove the negative? How do you prove that something doesn't cause an effect? Well, we all know that that's impossible. But what we do also know is that there are further studies that can be done and should be done. There are those who review articles. We actually just published a review article about this, looking at all the published literature on dydrogesterone, again, finding no safety signal. And again, the important issue here is that while the PROMISE trial, the trial I showed you in the New England Journal, showed no increased risk of adverse or decreased risk of adverse outcomes, that particular trial did not include dydrogesterone, primarily because dydrogesterone is not approved in the United States, and that was mostly a U.S. trial. So it's important to translate the worldwide research and clinical experience potentially for eventual use in the United States. So again, Zev, thank you so much for the invitation here. What are the take-home messages? Again, progestational therapies are associated with higher live birth rates in some studies of women and couples with recurrent pregnancy loss. Does not increase the likelihood of an abnormal conceptus. So if you have a conceptus with a chromosome abnormality, using a progestational therapy is not going to increase the likelihood of an abnormal fetus or an abnormal live birth. The PROMISE trial, as well as others, did not identify a significant higher rate of live births when progesterone therapy, micronized progesterone, and others were used in the first trimester. However, dydrogesterone, being that was a North American trial, was not used and included in the analysis. What we do see with dydrogesterone when it comes to recurrent pregnancy loss is overall higher live birth rate without any safety signals. And absolutely no validated safety data sets demonstrating any safety concerns with its use early on in pregnancy. So the call to action is to translate this worldwide research to make dydrogesterone available for clinicians worldwide, those engaged in research on recurrent pregnancy loss, as well as those who are providing care to women and couples who are suffering through recurrent pregnancy loss. Better options are out there, and we must not let innuendo or rumor cloud our ability to provide the best care to our patients. So with that, thank you so much. Stay well, and hopefully we are all together in person next.